Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAX. Thank you for joining me in my latest video using the WAXscope. So we have a really interesting case for you. Now, you may have seen this patient's ear before because they attend so frequently. They're having to currently attend every 6 to 8 weeks. And this has been ongoing now for the last 12 to 18 months or so. Prior to that, they would have to only attend every year. So they would come once a year to have their perennial ear clean. Therefore, I've written to this patient's GP on quite a few occasions now, requesting that an ear swab is taken of this patient's ear. But to date, for some reason, I'm not sure the exact reason why, the surgery haven't done that. And instead, this patient's been prescribed with topical antibiotics. So they suffer from otitis externa, which is an umbrella term given for an infection or inflammation of the outer ear. But this patient actually feels since taking the antibiotics, their symptoms have worsened and they're having to attend more frequently. Hence why I suspect this patient has got what we call otomycosis, which is a fungal infection. And fungal infections can occur for multiple reasons. One of them can be that your ear becomes quite warm and moist and damp. So fungi love dark, warm, moist conditions. But it can also occur secondary to use of topical antibiotics. So antibiotics not only kill or inhibit the growth of pathogenic, so harmful bacteria, but they also do the same for healthy bacteria. And the skin that lines the ear canal and also the rest of the body, it has its own skin flora. So skin flora is the best way to describe it. There's a whole entire ecosystem invisible to the naked eye that resides on your skin, and it's typically bacteria and fungi, and these are under normal conditions completely harmless. They reside there, they don't do any harm. So the same is true for the ear, but these if you have antibiotics, not only will it inhibit the reproduction of pathogenic bacteria, but also this natural healthy bacteria that lives in the ear, which then means that the fungus in the ear, the fungi, has no competition, which can then lead to an overgrowth of the various fungi strains in the ear, which then elicits an immune response. And when you have an immune response, you have increased blood flow to the ear, and that then stimulates additional skin growth. So skin production is fueled by blood flow, and the more skin that your ear produces, the more dead skin that eventually will accumulate. Now, in the majority of our ears, the skin should naturally migrate. So the skin that lines the ear canal, the superficial layer, the epidermis, it's almost like a conveyor belt. So the skin that you're seeing right now actually is produced and secreted at the center of the eardrum, a region called the umbo. So that's the progenitor site for skin production in the ear. And then this skin radially migrates off the eardrum and from the deepest region of the ear canal to the entrance. And when it reaches the outer third of the ear canal, the skin cells that form the epidermis layer of skin, they are normally interlocked, but when they reach the outer third, they separate from one another and they flake away, and aided by jaw movements, this dead skin is then naturally expelled from the ear. But of course, when you've got excessive skin production, your ear's natural conveyor belt, its natural self-cleansing mechanism, is not going to be optimal enough. It's not going to be quick enough to get rid of all this skin. So instead, this skin accumulates and it can form into a plug. Now, if you look at the patient's ear canal, there's, I wouldn't say it's swollen, there's no edema, but it is quite red, there's erythema. But this patient's experiencing no pain, no otalgia, which, as mentioned before, is more typical of bacterial infections. So what I'm trying to do here is separate and detach the skin plug from the ear canal, and you can see to the right it's just separated. I didn't use any forceps because this skin was quite soft, and normally with the forceps that I'm currently using. I've tried multiple ones. They tend to tear away the skin as opposed to extract the plug, which can be quite frustrating. So probably the next thing on my list to develop is some forceps are good with soft tissue removal. Now, I had a dentist from the States email me a couple of weeks ago with the name of a particular type of forceps that dentists sometimes use, and it's effective with extracting soft tissue. So now I don't think the design of those forceps in their current state, in their current format, is actually suitable for earwax removal, but I'm going to try and get a pair and just look at the jaws. It's all about the jaws, the serrations on the jaws, how they grip onto the skin, and maybe from there I can modify those potentially to design some forceps on the ear. But anyway, going back to the procedure, so I'm just dilating open the ear canal. I've separated the majority of the skin. You can see just to the left where I'm going now, it's still slightly adhered. You can see that kind of more adhesive outer layer, the skin plug, that's still semi-adhered to the ear canal. So I just want to separate that. Now, I would normally perform the procedure in this patient's ear using the iClearScope endoscope because it is a bit more of a complex one, but I wanted to put the WAXscope to the test today, so I decided to use the WAXscope. In fact, the right ear, which I'll show you in a different video, was a bit more complex than this. And I used the WAXscope there as well, and it worked really, really well. So I think I've detached the skin from the roof of the ear canal, from the anterior canal wall. I'm just going posteriorly once again to the back part of the ear canal, and you can see I'm just trying to peel it to the midline. So I'm going to the canal wall, getting a suction grip with the skin, and then bringing it into the middle, and then slowly bringing it away. So that was a long sheet of dead skin that was enveloped around the skin plug. So I'm just going to re-enter, going to dilate. We've got a good focus there, and I'm now going to just separate it from the floor of the ear canal. I think this is where the adhesions were at their strongest. You can see the underlying skin already. It's exposing itself, and it's quite dry and cracked. It's macerated. So I'm going to go back afterwards and peel that away. And currently I'm using the 14 gauge suction tip, or gauge. I'm getting different opinions on how it should be pronounced. When I read some of the comments, I'm getting corrected either way. So I've always been taught to say gauge, but I know others say it's gorge. So I will look at some of the comments later on after I upload this video, and maybe I should do a poll. So I've now though reverted to the 16 gauge or gauge, and so the outer diameter of the 14 gauge, it varies. It can be 2 mil or 2.1, and the inner diameter is about 1.7 and 1.6. Now, with the suction tips that I've developed, I've got a very thin wall thickness. So the outer diameter is 2 millimeters, but the internal diameter, which is kind of critical in terms of suction power, is 1.7, which basically means that suction tip that I've developed, it's narrower, and it may not seem a lot, like 2 mil to 2.1, but when you're in the ear, there can be a noticeable difference there. But importantly, although the outer diameter is a bit thinner than the norm, the inner diameter is the same, so it's not compromising on suction power, which can make it really good for narrow ears. So I've got more maneuverability, but the same level of suction power. But when I'm going close to the ear canal, you want to use a smaller suction tip. So normally I would use an 18 gauge or gauge, but that can get easily blocked because it's a very small internal diameter. I'm just trying to, I think it's around 1 millimeter. I'll come back to that in a moment. But the 16 gauge, the outer diameter, I'm forgetting all these measurements now, but it's 1.75, I think, or 1.65, and the internal diameter is about 1.25. So it's a lot narrower than the 14 gauge, but larger than the 18 gauge. So it's really good at peeling away dead skin. Now, I'm not going to get every little last flake out because the skin is macerated. And when the skin is macerated like this, you're going to be careful because it's easier to lacerate and cut into the skin. So there's just a bit in the isthmus. So as we approach the eardrum, the ear canal narrows, and you probably can see that. And I've decided to zoom in. This patient's ear canal is a bit longer than the average. So to get a good view, I've just zoomed in. I can't put the speculum in any further because it's just a narrow bendy ear canal. And we're now going to zoom back out. It's just a hair strand there at the entrance. I'm going to stretch the ear, so I'm using the right hand side of the speculum to dilate the posterior canal wall. And there's the eardrum, so I'm really happy with that. So it is quite a narrow ear. You can't see the anterior aspect of the eardrum because the anterior canal wall bulges inwards a bit. So there's that skin plug in the left ear. So I will try and upload their right ear procedure tomorrow, which again, as I mentioned, is a bit more complex. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon.